Hi, I am Amy McDevitt, Assistant Professor at the University of Colorado Physical Therapy Program. I would like to thank ELC for accepting our poster presentation today, and I'll be reporting on the results of a qualitative research study looking at the clinical reasoning assessment tool and how faculty perceived it and used it for development and assessment of clinical reasoning in physical therapist students. I am here presenting with other members of the team, including Mary Jane Rapport, Jenny Rodriguez, and Matthew Miller. We're really excited to present the results of our study, which we have in the form of a video poster. So the title of our study was Use of the Clinical Reasoning Assessment Tool to Inform DPT Student Assessment, a Qualitative Study. This was done at the University of Colorado Anschutz Medical Campus. So really the background in this was to further explore a tool that is evidence-based that was developed out of Creighton University called the Clinical Reasoning Assessment Tool. And as many of us know who are educators, clinical reasoning is really a multifaceted skill set. It is really crucial to optimal patient care and to healthcare delivery. But there is really evidence of inconsistency in our use of language to describe the clinical reasoning process really across DPT curricula. And so the ability to not only define, but teach, learn, and assess the development of clinical reasoning skills is really challenging due to the complex nature of the skill and really its abstract nature. The clinical reasoning assessment tool was really assessed to look at students' progress in the continuum of learning with the development of clinical reasoning. And so the clinical reasoning assessment tool has already been studied and has demonstrated some student progress across 4 time points in didactic and clinical components of a curriculum. So with that in mind, the purpose of our study was to explore how academic and clinical faculty, so clinical instructors, in a physical therapist curriculum used the CRAT to support the development and assessment of clinical reasoning in physical therapist student learners. So, as far as methods were concerned, we had 13 participants. We had 8 core faculty, 3 affiliate faculty, and 5 who were clinical instructors. All of these individuals had a common theme amongst them, and in that they utilized the CRAT with students either in the didactic or in the clinical education environment. So essentially we had 3 focus groups and we created an interview guide for the focus groups. These were audio recorded until saturation was accomplished, and each of these focus groups was approximately 80 minutes in duration plus or minus 5 minutes. As far as the data collection was concerned, again, it was guided by the semi-structured interview guide. And then really the focus group questions emphasize this larger construct of clinical reasoning. So we used a combination of probing and exploring questions in order to really get at the experiences and perceptions of individuals who had used the CRAT with physical therapist student learners. As additional components to data collection, we took field notes, and then we had multiple meetings to debrief and to discuss and clarify emergent themes or concepts, and then to identify where additional probing may be warranted in subsequent focus groups. After we collected the data, we gathered further descriptive information about each of the participants because we wanted to include a little bit more about their degree, their years of clinical practice, their teaching, and what types of students they taught. And we also wanted to know if they had specialist certification. So as far as data analysis, the verbatim transcripts were analyzed using a team-based approach among the co-authors. And a framework analysis was really used to identify our emergent themes. This down here, which I can put in a little bit more detail, includes a table of the participants. So the participants had a variety of highest earned degrees. The majority of them were ABPTS certified specialists, and this indicates what their roles were in the program faculty. So again, we had core, affiliate, and then clinical instructors. We also wanted to indicate if their involvement was with more of the beginner learner, which we really defined as working in the foundational courses and sciences in year 1, or were they more involved with the intermediate learner, which is really more of what we call the track courses, which include neurology, orthopedics, and some of those more advanced and examination and intervention courses that are taught in the 2nd and 3rd year. This indicates the number of years that each of the participants has been really a individual working within the CUPT program, clinical years of practice, and then the practice setting. So if we look at the tool itself, the tool was given to each of the study participants just to provide further context during the interviews, so they were able to refer to the CRAT and be reminded of some of the language and the different domains that are housed within the CRAT. So these are the 3 domains that are housed within the clinical reasoning assessment tool. And so this tool, again, was really developed to support development and assessment of clinical reasoning across a continuum, which is why we have been utilizing this in our curriculum across a number of courses, as mentioned, from the beginner learner to the intermediate, and it has also been used in our pediatric residency program. So to familiarize you with the domains, we have content knowledge, which is really foundational knowledge, integral to the health condition. It includes biology, and also, though, includes the ICF. So the ICF components and definitions, which are related to the patient's health condition, body structure and function, activity and participation, and then other contextual and environmental factors. Procedural knowledge is really what dials into the student's ability to perform skills. So this is really their psychomotor skill development. It includes choosing appropriate tests and measures, but also choosing appropriate interventions. Communication strategies, both verbal and nonverbal skills, are also integrated into procedural knowledge. The final domain is conceptual reasoning, which really includes the metacognitive skills, reflection, seeing interrelationships, synthesis of information, and making judgments. So these behaviors include things like adapting interventions or tests and measures, interpreting findings, and then applying what they are interpreting across all aspects of the ICF. So this is really where everything seems to more or less come together for the learner in the context of a patient encounter. Each of the faculty that were included in this study are very familiar with both the sample behaviors and then the visual analog scale, which goes from beginner through intermediate. So when faculty are scoring the CRAT, they're going to score according to kind of a combination of looking at sample behaviors and then trying to determine, for example, in this procedural knowledge domain, how much accuracy did they have and were they safe? Was accuracy limited, moderate, strong, or were they considered much more efficient in how they performed examination skills as well as interventions? So that is pretty much the clinical reasoning assessment tool. So when we look at the results from the qualitative study, one thing that was really interesting and I think optimistic is that we were able to determine from the qualitative data that all of the participants really similarly defined clinical reasoning. And so this first quote at the top is really a distilled version of a lot of these comments coming from the participants, and that clinical reasoning is what the student learns from the subjective history, the exam, and then condensing it down into something clear and solid while integrating didactic knowledge and the hands-on skills that are relevant to the patient in front of them. So we did see more or less consensus surrounding how people were defining clinical reasoning. So as far as the various themes that emerged from the data, the different themes you can see are over here on the left. So the main themes that we found were that the CRAT provided organization and structure. So it fostered understanding of clinical reasoning through organization and structure. Another theme that emerged was dialogue and self-reflection. So participants stated that this tool really facilitated clinical reasoning through dialogue and and self-reflection, including the ability to articulate a rationale for the decision making. And further, faculty were able to articulate that it was the tool itself that allowed faculty to be more organized in their approach to a dialogue with the student, but also in helping that student to self-reflect on their patient encounter. And finally, we came up with a theme of benchmarking. So benchmarking is really assessment of the clinical reasoning in the learner using those sample behaviors and the visual analog scale. So this is, again, based on a continuum from beginner to proficient. So we did really find that the clinical reasoning assessment tool wasn't just about helping to provide a language and facilitating structure, including dialogue and self-reflection. It was also used as a tool for assessment. So if we go back to organization and structure, which is here, the participants really agreed that the domains of the clinical reasoning assessment tool organized the faculty and the learner during a patient encounter, and this was carried over from didactic to the clinical setting. Some sample quotes from participants were, "The CRAT may have provided structure for beginner and intermediate learners, preparing students for a patient simulation-based or clinical encounter. Additionally, the CRAT may have helped by providing students with a different way of looking at their own clinical reasoning development." And finally, the CRAT in its organization, quote, "takes you through a patient encounter. The content knowledge is the chart review, procedural knowledge is carrying it out, and conceptual reasoning is on-the-fly modification based on what you're hearing and seeing during the patient encounter," end of quote. So again, the participants acknowledged that the CRAT really provided them with some structure, and it really provided a framework of guiding questions that really helped the student recognize the importance of the why of what they chose to do. But a limitation of our study was that we did not sample student participants. So that really is something that's probably more relevant to our discussion and conclusion, but I just wanted to remind the viewers that this really was just about faculty perception. But faculty did believe that it helped set expectations for students. The second theme here, dialogue and self-reflection. So what happened here is that participants found the tool to be helpful in guiding dialogue after an assessment. It helped them with reflection, and the CRAT, in their opinion, guided deeper dialogue by having the student justify some of the decisions that were made during a patient encounter. And some participants mentioned that it gave them a different window into the thought process of what the learner may have been thinking. So to give you some specific examples, the first quote, I just flat out say, "If you were to consider the knowledge about the situation, how you used your hands, and what you were thinking about your decisions, which did you feel strongest in and which was the hardest?" Another quote, "When an instructor asks guiding questions, the instructor gets a different window into the thought process of what the learner was thinking while they were doing it." And additionally, another participant stated that the CRAT really helped the student to frame their thoughts from a reflective standpoint. Another participant stated that they found the CRAT to be a helpful guide to reflection. "I rate them, they rate themselves, and we see how close we were." It was helpful to see what the student noticed. And so out of that quote, you may understand that some clinical instructors or clinical faculty gave the CRAT for the student to reflect on, while they also reflected on that student. And it gave them really a platform to compare notes about how they both thought they were doing. And many of the participants agreed that the student's ability to reflect on the encounter is really critical to developing clinical reasoning. So the CRAT may have provided really a tool for reflection in allowing the student to spend some time thinking or writing about maybe where they struggled with a complex patient. And finally, we have benchmarking. So as far as benchmarking, all the participants reported using the CRAT to benchmark. And one participant stated that they observed the students' overall performance and then really honed in and scored them based on their consistency at a certain level on that continuum. So really, they benchmarked the students' ability to make decisions, and sometimes it was based on a novel patient situation, and sometimes it was a follow-up. The second quote, I considered entry level to be competent and used that as a starting point. Third quote here, the first two domains drove the third. So content knowledge and procedural knowledge the student can potentially be great at both of those, but then not do as well on the conceptual reasoning or vice versa. So overall, the participants found the domains and the sample behaviors in the CRAT to be useful for benchmarking the learner, and they recognized that there were interactions between the different CRAT domains. So if we go to looking a little bit more at our discussion following this research study, we do recognize and validate again that clinical reasoning is complex due to its contextual nature, and it is very difficult to define, teach, and assess. And the CRAT was initially developed to really fill a void in clinical reasoning assessment. And what we found is that faculty use the CRAT to support the development and assessment of clinical reasoning within 3 themes: fostering understanding of clinical reasoning through organization and structure, facilitating clinical reasoning through dialogue and self-reflection, and then assessing clinical reasoning in students along the continuum of learning through the use of benchmarking. And why we think some of this information that we're putting forward is important is because we really have been called to arms nationally to really look at how we integrate learning theory and learning sciences into how we teach. And clinical reasoning is a huge component to this. And so in order to make, really move the needle on clinical reasoning, we need to be able to come up with tools that we can study and understand. And I think the side effect of these tools are common language and common approach to the teaching and learning of clinical reasoning. So as far as the conclusions, we know that clinical reasoning is a critical skill set for physical therapists, and there's limited guidance to support the teaching and assessment of clinical reasoning. The CRAT may serve as a useful tool for faculty to improve development and assessment of clinical reasoning. And we know that in this particular instance, it provided structure and organization and may support faculty in their work to further learners' understanding of clinical reasoning and provide more objective assessment using benchmarking in domains of learning within entry-level physical therapist educational programs. These are our references, and we would like to thank the Academy of Medical Educators and the Reimer Grant for funding all of the work that was a component of this qualitative research study.